All right. Hell yeah. Focus on content. The content is the important part. Okay, we're ready? Ready? Is everyone here? 11, 12, 13. I think 3 people online. So, can you figure out who's not here? Would you mind? Thank you. Okay, we're going to get cracking. A little shortness of breath. Part 2. What? Yeah. All right, let's roll. I'm going to make this quick so we can get to practices. Does everyone have a team name?
We are called Heather the Zets.
That's fucking awful, man. Is everyone planning on making their own team logo? Are you noodling that yet?
Think about it.
We have to make a name first and then we'll
Do some noodling.
Do some noodling. Let me know. All right.
When do we need that noodling done by?
If you have a concept within a week, so we can get the embroiderers to put it in the thing. There's a thing. I was gonna do something very similar to that, but like just with a little plus sign in a circle. But yeah. All right. Let's do it. Okay, here we go. Shortness of breath 2. Return of the shortness of breath again. Fuck that. Yeah. All right, here we go. Common causes we talked about last week. Does everybody remember what the common causes that we talked about last week were? Asthma's a good one. Yep. ACS, nice. COPD, CHF, PE, yep. The pulmonary embolism kind, asthma, COPD, pneumonia. I don't think that one's in here. That one's in something else. But anyway, okay. So, common causes of shortness of breath. We have had some scenarios now with some of these common and then slightly more weird causes of shortness of breath. Does anyone have any questions or anything that's been bothering you since your team training days or your all hands training day with regard to the content that we want to talk about now? Go.
Just real quick recap on when we want to use BiPAP/CPAP.
So quick recap on when to use BiPAP versus CPAP. There was some kind of kicking around about this over the past couple of days. Long story short, either is better than nothing, right? So in any situation where you're thinking, I need positive pressure ventilation, and you're like, do I do BiPAP or CPAP? Don't let yourself be so derailed by trying to figure it out that you don't do one of the two, because one of the two is going to be better, right? There's kind of conflicting evidence about whether or not, like specifically in congestive heart failure, you want to use CPAP versus BiPAP. If you kind of logically think about it, you'd be like, oh, CPAP because it has more pressure constantly. That's going to hold the water out of the vessels pretty well. In reality, I did some digging into this over the past couple of weeks. It's like really the difference in patient outcomes isn't super significant. So, but realistically, BiPAP is kind of the general idea is BiPAP is for type 2 respiratory failure, CPAP for type 1 respiratory failure. So you think about like BiPAP is going to make you better at blowing off CO2 because you decrease the pressure on exhalation. So if you have a buildup of CO2, hypercarbia, BiPAP is going to be a little bit better for that. It's why people tend to err on the side of BiPAP regardless, because like for type 1 respiratory failure, they're probably going to perform about the same. But like Emma said the other day, BiPAP for type 2, CPAP for type 1. And if you guys want to just take that away and use that, I'm fine with that. I think that'd be fine. Any other questions? Cool, let's vibe on. Rare causes. Shortness of breath. Pleural effusion. It's a pretty big one, yeah.
Sorry, I was quick.
Yeah, go for it, Ruby.
So is there any situation where you should not use BiPAP or CPAP?
Hey, guys. Is there any situation where we shouldn't use BiPAP or CPAP and lose the SimWars competition because you use BiPAP? Yeah, so anytime you have an actual like trauma, you do not want to use BiPAP or CPAP. So if you have, when we talk about our pneumothoraces, right? Anytime you have a pneumothorax, you're avoiding positive pressure ventilation at all costs, right? Because we start to put more pressure in there, that's just going to put more pressure in the chest cavity. So that's a big contraindication of BiPAP or CPAP. Another less big but still fairly large contraindication to BiPAP or CPAP is hypotension. So if we think about it, when we start to push that positive pressure air into the thoracic cavity, that increases pressure in the thoracic cavity, which definitionally will decrease venous return. So if we already have a preload problem that's causing us to be hypotensive, it's going to make that worse, right? So we want to try to manage that before we start the patient on BiPAP or CPAP, right? Now, obviously, breathing comes before circulation. So at the end of the day, we work on that. But if you're kind of borderline and the patient's pressure is 80, we avoid that. Another really common contraindication and something that people tend to forget is to use BiPAP or CPAP, you must have a good respiratory rate. If you have a bad respiratory rate, they're going to be useless because they're not actually controlling whether or not you're taking a breath in. They're just feeding you air when you ask for it. So if you don't know to ask for air, it's not going to happen.
So like for good respiratory rate, you mean like 12 and above? Or?
I'm thinking like 8 to 28.
Okay.
Right, you're going to have people that are super short of breath and breathing fast. So it's really like you don't want the respiratory rate to be 4. You don't want to think the BiPAP is going to ventilate that patient for you. But it's kind of a judgment call, right? If you think they're adequately they have adequate drive, but they're just not able to get that air in, that's an okay time to use CPAP or BiPAP. Anything else? All right, cool. Spontaneous pneumo, we kind of talked about that a little bit last week. We'll talk about it some more here. We're going to talk about primary hyperventilation. Less common thing, something you won't see super often in similars, but something we do want to kind of cover because it happens in the real world. We'll talk about respiratory compensation. This is kind of an interesting one. I just want to get this into your heads as a thing because there's many a scenario that has gone awry because we've assumed that because a patient's breathing heavily, they have a breathing problem. And we don't want to make that assumption because there are some things that can fuck with that, right? This was big sexy the first year we made these lectures because it was like COVID time. Now it's kind of like not rare or sexy anymore, but we're going to throw it on there just because sometimes people are like, oh, we're going to throw them a COVID scenario because it's relevant to the times. Whatever, fuck them. All right. We talk about this every week. Secondary survey, OPQRST or Socrates if you're a nerd. Sample, use them. Don't forget them. Very important, especially when it comes to medical complaints. We got to get this information in as fast as we can. We've had some conversations, some questions over the past few days about what do we want to ask if we have a patient that's super sick. I want you guys to go for the sample stuff first if we have a patient that's super sick, right? Because if a patient fucking crashes on you and dies, I'd much rather know that they're allergic to, whatever drug than the sitting up makes their pain feel a little bit better, right? Because now I don't care because they're dead. But I do want to know if they have allergies. I do want to know if they're on medications. I do want to know about their medical history. So when we talk about sample and OPQRST, sample first, specifically the AMP of sample, the first things we want to get, right? We want to know if we're allergic to anything, meds, past medical history. Then make a judgment call, all right? Secondary survey respiratory, we talked about this a bunch. There it is. Inspect the airway, inspect the chest, palpate, auscultate, percuss. Percussions, whatever, fuck them. Cardiovascular survey as well, and again, we're going to nail this down. Every respiratory patient gets a cardiovascular assessment as well because the overlap between the two things is so significant that we are not going to miss stuff, okay? We've had 2 patients in our team trainings this week. They both had respiratory conditions that were also kind of cardiovascular, right? So the overlap there is really significant. So we want to make sure we're doing those assessments as well. All right, let's talk about some rare causes. Pleural effusion. What is it? Yeah, it's fluid in the pleural space outside the lungs that's not blood, right? And by fluid, we mean liquid because gas would be a different thing. That would be a pneumothorax, right? So liquid in the pleural space outside the lungs that's not blood. Exudated versus transudated. Fuck your lights criteria. Explain to me what they mean. What's an exudate versus a transudate?
High protein is exudate.
What do they mean? So transudated stuff's getting pushed through, right? Because there's too much pressure, stuff's getting pushed through. Exudated stuff leaking through because it's too weak, right? That's the end of the day. So our exudate's going to be stuff like So our kind of inflammatory processes, right? You said it, inflammatory stuff, infection, whatever. Transudate's going to be things like
heart failure.
Yeah, so our heart failure, hypertension, stuff like that. Great. Okay. So, what are our pleural effusions going to look like? What are they going to present as they come into the emergency department? What are we going to see on these patients? So we'll see shortness of breath. Great. We'll see dyspnea. Absolutely. So you may see pleural pain. Yeah. So deep breath in hurts. Right? And normally tends to hurt where the effusion is, not always. What else?
Maybe it's worse when they die down.
Yeah, so worse when they lie down is a really good one. These tend to be a little bit better when we're sitting up, just if you think about how gravity works.
Would it be possibly deeper breaths or not?
Sometimes, but you tend to see them like trying to take a deeper breath and failing.
And then if they have a fever, you might be thinking, oh, it could be.
Yeah, so they were starting to unlock the symptoms due to the cause. So maybe if it's an infectious or parapneumonic effusion, we're going to have symptoms of pneumonia, right? Or if it's malignant, we might have B symptoms of malignancy, right? That doesn't tend to be a super emergency, but we may have, what else might we have?
Heart failure.
So everything in heart failure could be like, maybe what do we see? We saw it this week.
All the edema stuff?
Yeah, so we may see edema stuff. We might see pulmonary or pedal or sacral edema. We might see other issues with things to do with heart failure. We may see tachycardia, right? We may see all these different signs. What else?
I think maybe cough.
Yeah, so you could have a cough depending on the cause of the effusion. Absolutely, could have a cough. So what are some of our big causes of effusion, right? We talked about parapneumonic effusions. We've talked about our sort of like congestive heart failure related or transitive effusions, malignancy. Anything else anybody can think of? Say again?
No, I just said TB.
Yeah, so that's not parapneumonic, that's tuberculin, but yeah, absolutely. What else? Anybody? Yeah, COVID, sure, absolutely. If there's something you're like, I don't know what the answer to this is, if you say COVID, like odds are somebody in the world has had this weird fucking presentation. All right. So what are we gonna do to diagnose? You've seen a couple of these chest X-rays now. I think we all can see like what the fuck's going on here, right? Like this whole area, there's nothing there. It's all filled with goo, right? So that's your effusion. That side's normal. Look at another one. That's a really nice one. You got a nice line there, really simple. Boom, good on this side, right? So our investigations: pulse ox, end-tidal capnography. We'll talk a little bit more about end-tidal capnography as we get to the end of this thing because I had some questions this week. Bloods, ABG, VBG. One of the things that we came up really, really common over the past week has been, which of those two is better? An ABG, right? So if you order both, don't fuck around with the VBG, just look at the ABG, right? You're like, okay, fuck it, VBG, ABG. And if you're ordering both because you're just kind of in the route, that's fine. But with a lot of these respiratory patients, you want to try to get an ABG if you can, right? The other thing I want you guys to remember is if you get a VBG, the numbers are going to be different than the ABG normals because the blood's already gone through and done its shit, right? So you're going to see what's going to be different in your VBG. Lower PaO2, right, because you've exchanged oxygen with the cells. Maybe higher CO2, right, which leads to lower pH. Great, okay. So just remember, if you get a VBG back, don't look at it from the lens of the ABG values or the normal values.
So do you mostly look at a VBG for lactate?
So when you get labs, you look at the labs for everything that they're worth. But in a lot of cases, a VBG is useful for the lactate, yeah. But like if you get a VBG in a respiratory patient, like still look at that stuff. But it's not going to be as good as an ABG, all right? Ultrasound, we can use an ultrasound here. For Sonogames, people will talk to you all about that. We can use an ultrasound to see these effusions. Chest X-ray, what do we see on chest X-ray? They call it blunting of the claustrophrenic angle. That whole thing's filled up with fluid. It's obvious that that's bad, right? Cool. Then look for the cause. So what are we thinking when we're talking about causes? What might we do? Searching for causes. Yeah, so it's pneumonia looking for consolidation. You might need a chest CT, right? What else?
CRP.
So CRP, ESR, inflammatory markers for sure. Blood cultures is great. So now we're starting to think about infectious causes, pneumonia, things like that. Awesome. So you guys are thinking. That's all we care about. Now here's your lights criteria, you nerds. Do I need you to memorize this?
Yes.
I don't need you to memorize this, but the school needs you to memorize this. So you might as well fucking do it, right? So realistically in SimWars, are you going to be sitting down like doing interpretations of a pleural tap and the values? No, you're not going to be doing that. You're not going to be getting that pleural tap. You're not going to be looking at that fluid. There's not time for that. But I do want you to know that this exists, and I want you to know based on the clinical picture of the patient what you're more likely to see, right? So if we have a clinical picture that looks like heart failure, you're more likely to see a transit. That's it. You do need to know this, but not for us. So I would know this at some point, but whatever. All right. So how do we treat pleural effusion?
Take it out.
Yeah, you can take it out. Do we always take it out? Not always, right? Depending. So we got some options up here. Stabilize our patients with respiratory distress. We give them oxygen. We treat the underlying cause, whether that's with antibiotics for pneumonia, diuretics for our CHF. We're not oncologists, so we're not going to fucking fix their malignancy, but we can do our best to help out symptomatically. As far as their urgent reasons to drain that fluid, and these are things that will come up in SimWars, signs of increased work of breathing. So if we're really like working hard to breathe to the point where the patient's going to tire out, respiratory failure, so we're looking at that ABG, hemodynamic compromise secondary to the effusion. Why might that happen?
Pressing against the word.
Yeah, so you get a big fucking piece of thing in there that's just causing all sorts of venous return problems. So then we would treat the cause, or we're going to refer them to treat the cause. All right, so we may not be able to fix this. We might be able to say, okay, that's an effusion because of malignancy. We're going to make them feel better, but at the end of the day, it's not our job to fix that as an ER person, right? All right, cool. Spontaneous pneumo. Talked a little bit about this one last week. What are we thinking? Who's our spontaneous pneumo patient?
Tall, skinny man.
Yep. Tall, skinny guys. Matt's our spontaneous pneumo guy in this room right here, right? So we got our tall, skinny males, tend to be pretty healthy, tend to be pretty active people because you need like movement and trauma to cause a spontaneous pneumo. So this is a collection of air in the pleural space, outside of the lung, but in the cavity where the lung is, non-traumatic. And we're talking like there is probably some amount of trauma involved, but there's not normally a traumatic injury. That's why it's spontaneous, right? Primary spontaneous pneumothorax. These are patients without any underlying lung disease. So these are our healthy 19-year-old tall guys that just, boom, pop one off, right? Secondary spontaneous pneumothorax, this is a complication of an underlying lung disease. So what are these people? These are our garbage COPD patients, right? These are our really sick COPDers, normally the emphysema side of COPD, where the alveoli get really, really big and really, really skinny. We call those blebs, right? You pop a bleb real quick, you got a spontaneous pneumo. Bada bing, bada boom. That's it, all right? Do we put CPAP or BiPAP on these people? We sure fucking don't, because that's how we lose SimWars. All right. No, we didn't do
It's a
it.
safe space, Ken. It's a safe space.
And you said it was spontaneous pneumothorax, and you said it was in the heart failure.
So hypotension.
Hypotension.
All right, so take a look at our characteristics of pneumothorax here. This is our sudden onset shortness of breath, right? You pop that pneumothorax going, and almost immediately we're short of breath. Almost immediately we have chest pain. It's not like this, oh, I've been getting sick for the past 4 days. It's like I was walking and now I am short of breath, right? Unilateral paralytic chest pain, acute shortness of breath. What do you think this might be confused with sometimes? PE, right? Because those are the same kind of things. Paralytic chest pain, unilateral, normally localized, acute shortness of breath. Risk factors, tall, thin males, connective tissue diseases, right? So things like Marfan's, more likely to get these. Take a look here. These are going to be closed pneumothorax, right? So we need air in the pleural space, but it's coming out of the lung. It's not going anywhere else. These are our trauma pneumothoraces, right? So open pneumothorax, that's a hole in the chest wall. That doesn't happen spontaneously. Someone's got to shoot you or stab you for that to happen. And then our tension, which we'll talk about later, this is our trauma related when we start to really build up that air in that cavity and decrease venous return to the heart. Closed pneumothoraces don't normally become tension pneumothoraces unless you do something really dumb like putting them on my pad. Okay? And again, I'm not calling out anybody. We did it right. It was one of the other teams from one of the other schools that fucked it up, and that's one of the reasons that we won. All right, check that out. There's our chest x-ray. You guys see that? What do you see? Yeah, so look, we got nice, like a bunch of like white lines and shit over here. That's lung. It's gone. It's all in this little one right there. Little tiny guy. That's all filled with air. Easy enough. Pulse oximetry and tidal. Bloods, again, our ABG if we can. ECG, chest x-ray, what do you see? You see air, because there's air in there, right? Pretty obvious stuff. Are they always this stupid, right? No, there's oftentimes a much thinner line of air in spontaneous pneumothoraces. This is like really bad, okay? You can use ultrasound to diagnose these two. Sasha stepped out, but when he comes back, he can tell us all about how to diagnose pneumothoraces on ultrasound. So here's a little flow chart. We talked about this very briefly last week. These guys, we can sometimes treat outpatient, or at least let me rephrase that. We can sometimes treat them without actually draining that pneumothorax, right? We can treat them without placing a chest drain or decompressing. And the threshold for that is normally a 2 centimeter margin of air, right? If we're smaller than a 2 centimeter margin of air, oxygen normally will resolve these patients on its own. If it's larger than a 2 centimeter margin of air, normally we'll need to go in and place a small chest tube to take that air out, okay? That's basically all this is. Tells us a little bit about exactly how to do that. That's fine, right? Normally in sim wars, somebody comes in, they're going to be the one that you need to fix, not the one that you're going to be like, oh, we'll just watch them for 4 hours, right? Because that's not how the game works. Primary hyperventilation.
Panic attack?
Yeah. Anything else? Could be. I maybe would call that like secondary, because like secondary people whack. Right. So primary hyperventilation, we start to hyperventilate. There's not really like a pathological physical cause to that. Panic attacks are a really classic one, right? What are our patients going to present like? I'm going to stand in front of this. What are our patients going to present like with this? Yeah, we're going to present as we're going to feel like we're dyspneic, right? We're going to be like, oh my god, I can't catch my breath. What else?
Dizziness.
Maybe dizziness.
With panic attacks, it might just be sweating.
Could be. Yep. Sweating is the thing that Header said there, guys.
Chest pain.
Maybe some chest pain, absolutely. Anything else? One of the really common ones that you'll see is paresthesias.
What is that again when you're not?
So when you feel that, like pins and needles in your fingers and toes normally. Anybody know why? Nah.
Carbon dioxide?
Yeah, carbon dioxide. So if we start breathing really fast, but we don't need to be breathing really fast, we blow out all of our CO2. Goes away, right? No more CO2, paresthesias. What does that do to your pH? Makes it go higher, right? Because we're getting alkalotic, because CO2 is functionally equivalent to acid. So this is our primary example that you'll see a lot tested in like the steps and stuff of our respiratory alkalosis. Right? Our primary hyperventilation is an example of a respiratory alkalosis. Okay? Diagnostics, again, we don't know that it's primary hyperventilation until we've proven that there's no other cause. Right? So we got to do the work. We've got to get through our pulse ox, end-tidal capnography, bloods, chest x-ray. It's going to show probably normal, but maybe there's something going on there that you didn't see. Right? And you do not want to be the person that dismisses a PE as a panic attack, because then you're in hot water and you're going to lose like $1 million. All right? And maybe someone's going to get hurt. You're going to lose like $1 million. Okay. So how do we do this? We rule out other causes, keep the resus calm, keep things in the zone. I know we're good at that. Reassure the patient, and we do something called breathing coaching. Does everybody know how to do this?
Like box breathing.
Yeah, basically. There's a few different methods to do it. We'll talk about it. We'll do a scenario on it at some point or another. But basically, you're matching the patient's breathing rate and trying to bring them down with you. There's a few different methods that we use to do that. Do not make them breathe into a brown paper bag. Don't do that. Okay, cool. Respiratory compensation, another rare cause. This is when we're responding to something else. So what happens in respiratory compensation? So yeah, something's messed up. Normally the kidneys, or maybe something else. Could be toxins, great one. Could be blood sugars, or we could be thinking about DKA, really classic example, right? Yeah, it could be infection, right? It could be getting acidotic due to that, right? So we get acidosis for whatever reason external to the pulmonary system, and then all of a sudden we've got a bunch of acid that we need to get rid of, right? And our kidneys are good at processing stuff, but they take a while to respond. So if we can blow off that acid in the form of carbon dioxide, that's good. So we compensate, right? And this is one of these things that it's like, ooh, it's pretty rare, but if you miss it, you're fucked, right? So one of our really classic examples of this is our Kussmaul respirations and diabetic ketoacidosis, right? So you get that acidosis, get those Kussmaul respirations, rapid and deep respirations, trying to blow off that acid. That's what happens. So what's our patient presentation going to look like with a respiratory compensation for metabolic acidosis?
They'll be hyperventilating.
So yeah, they'll be hyperventilating. Great.
You'll have that tremor.
Oh, they may. They may have that tremor. You know what that tremor is called?
Wait.
Asterisk.
There you go. Flopping asterisks. Very good. All right, so they may have that. Am I going to like make you guys do like the hands inspection for Simwars? Probably not, but like, What are we going to see with these patients?
Someone with DKA.
Or any sort of metabolic compensation or respiratory compensation for metabolic acidosis. So you might see the fruity breath. That's a good DKA finding, right? Acetone or fruity odor on the breath. What do DKA patients tend to like present with? What's their history tend to be like? Yeah, they have diabetes. Very good. Very good.
Maybe they went drinking.
Okay, so we'll normally have some sort of inciting incident, right? Whether that's an illness, like a GI illness, nausea, vomiting, whether that's an infection, whether that's something like getting on the bend, getting on the rip tear, that's fine, right? We're going to have some inciting incident. Are they going to be diagnosed with diabetes every single time? Or your DKA patient going to be diagnosed with diabetes? No, there is a common eventuality where a patient is diagnosed with diabetes the first time because they go into DKA, right? DKA is, what kind of diabetic is that? Type 1, right? What do our type 2s get? Step question.
Or
HHS now, but yeah. What was the first one you said?
Punk is what we used to call it in Ireland for years.
What was that? What did that stand for?
Hyperosmotic non-ketosis.
Oh, hyperosmotic. Okay, yeah. So HHS now. So what is it? Hyperosmotic, hyperkalemic hyperosmotic, whatever the fuck. Doesn't matter. HHS. So these patients will present very similarly, but they'll have different background histories, right? So our HHS patients will have basically a longer lead up, or diabetic ketoacidosis is going to be a shorter lead up. Lots of different things. But at the end of the day, this is a respiratory compensation for metabolic acidosis. What other things? You brought up a toxin. What's a great toxin example of hyperventilation?
Is it the liquid thing for the car?
Antifreeze.
Yeah, for antifreeze.
Yeah, so ethylene glycol, sure, yeah. That's a good one. That's a really solid one. Anybody else got one? What's an acid that's really common? Aspirin, acetylsalicylic acid. Yeah, absolutely. So ASA overdose, another one that can sometimes cause our hyperventilation, right? It's a lot of different things. At the end of the day, if you have even a tentative understanding of the buffer curve here, what's the name of the guy that invented this?
Hasselbalch version.
Yeah, was it Hasselbalch or something else
The
too?
buffer.
Well, this is a Henderson Hasselbalch equation, but the buffer curve has a different name. Anyway, long story. That's the carboxyhemoglobin dissociation or oxyhemoglobin dissociation curve. Anyway, if you have even a bare minimum understanding of that, you'll be fine, right? So if you get too much acid because of an outside cause, you'll start breathing too fast to try to get rid of that acid, because hydrogen turns into CO2 through magic chemistry. Cool. All right. So we diagnose these patients. Pulse oximetry. End-tidal capnography. Useful here? Yeah, very, right? Because it shows us up to the second how much CO2 we're getting rid of. So if we're breathing rapid and deep, super rapid and deep, if there's no underlying pathology, the exhaled CO2 is going to be low, right? If there is an underlying pathology that's causing that and we're compensating for something, we're going to still be exhaling normal to high amounts of CO2. So a really great way to differentiate between our primary hyperventilation and our compensation, right? Bloods. Glucose is huge. Glucose is huge in every patient, but it's super huge in these patients. You have a patient come in breathing 50 times a minute, bang with the thing, the little meter goes HI, then you know what's going on, right? Simple as that. ABG, special attention to anion gap. How do you calculate an anion gap? I'm playing. I'm fucking playing. I'm playing. There's an equation. Don't worry about it. And we'll see metabolic acidosis. We are going to have a little session on how to read and interpret ABGs here in the next couple of weeks, so don't get too freaked out about that. Then we start digging for why they're in this state to begin with, and we're talking cultures, we're talking blood count, we're talking urine electrolytes, we may be talking MSU, so urine sample with dip, and then microscopy, maybe they're UTI, another really common cause. So the underlying idea here is to find the cause. Look at how big this guy's kidneys are. They're so fucking, look at that. There's like his whole abdomen. Crazy. All right. What's next? Yo.
Kind of unrelated question, but
Yeah.
when you want a urine sample at a patient who's similar, do you have to ask them to, like, do you pretend you're putting in a catheter?
So it depends on the condition of the patient, right? If there are some patients that come in that are like in an okay enough condition that in the real world you'd be like, hey, can you give me a urine sample? It's okay to do that. Obviously, they're not going to whip it out and actually like pee in the scenario. They'll be like, okay, you got your urine sample, right? But in a situation where the patient's obtunded or in pretty much all of these cases, these patients are getting a urinary catheter. And you will be not asked to do that. You may be asked to do that in the semifinals would be the only time that would happen. But just because the mannequins aren't equipped to do it most of the time.
Like if we're doing like the sepsis 6, they were taking urine output.
Yeah, you're gonna say we would start a Foley catheter, right? Because you're gonna Please, sir, can I have some more? Yeah.
Use the very septic technique.
So
Yeah, I think we should put a urinary catheter.
just get your grumpy little paws in there. Yeah. So the answer to the question was basically, we have a patient in SimWars, we need to get urine for whatever reason, whether it's monitoring output for sepsis 6, whether it's a sample for dipstick or microscopy, whatever. The answer to that question is, say what you want to do, and say how you would do it given the patient's presentation. So if they're conscious, learning, or any times 4, you could say, hey, I'd ask this person to provide a midstream urine sample, right? If they are obtunded in any way, say, hey, I would place a Foley catheter at this point. If the mannequin's equipped to let you do that, they may ask you to at least walk them through how to do that. But odds are it won't be. Question?
Why does it have to be midstream?
Why does it have to be midstream? Anybody?
Just better sensitivity.
Because there's bacteria.
Yeah, so if there's bacteria at the end, so you start the pee, knocks all the bacteria off, get the midstream, then that's bacteria from the middle. You know what I mean? So there's bacteria around the urethral opening, and if you get it midstream, you've cleared some of that bacteria off. It's slightly more sensitive, and it's not going to grow as much, just like random skin bacteria, right? That's all it is. Is it still going to half the time grow random skin bacteria? Absolutely. Whatever. COVID-19, there she is. Beautiful.
Take that picture.
Gorgeous, isn't she? Now, in these trying times, we must all come together in this unprecedented moment to talk about COVID-19. All right, real quick, because it does tend to come up. So, we all fucking know this at this point. This is not new news. It used to be new news. We have our kind of classic COVID pattern. Obviously, this got blown the fuck out because people keep presenting with all sorts of crazy shit. But fever, cough, dyspnea, loss of sense of smell and taste is still pretty out there. Sore throat, myalgias, headaches, right? These are the patients that you'll see in SimWars. You won't see the, oh, I'm sick, please write me a note so I can not go to work. You'll see the fucking ARDS, like, dying person, right? So, what are we going to do for these patients? Yeah, COVID test. What?
Curb them.
Yeah, so curve them, right? Kind of treat it like a pneumonia aside from our antibiotics, right? And if we don't know, we're going to treat it like a pneumonia all the way. COVID-19 diagnostics, pulse oximetry, end-tidal COVID swab. Duh. ABG, UNE, full blood count, blood cultures. Because we don't want to screw up COVID v bacterial pneumonia. What do our chest x-rays tend to look like? Kind of fucking, like, general garbage. Right? You're not going to have, like, a lobar consolidation in most cases. You're going to get, like, general garbage. This is a good one. You kind of got this just, like, fluffy opacities kind of all over the place. Nothing super specific. That's a COVID. How do we treat COVID? Ivermectin. All right? Get the paste. Put it on the inside of the nose. So how do we treat COVID? Ventilatory support. These patients can get positive pressure ventilation, CPAP or BiPAP. In severe cases, they may need to be intubated. We know how that works. We've all been living this for the past few years. This isn't anything special. Hemodynamic support, supportive care. It's a virus, right? So we have some options as far as viral treatment goes, but at the end of the day, the things to fix here are going to be our basic supportive care stuff, right? And those are some of those weird ones that they came up with as the COVID pandemic was evolving. There's now that Paxlovid that is out there. That's not for admitted patients, though. Remdesivir is still the call for admitted patients, right? And, like, dude, hit that ivermectin.
This might be a stupid question.
Yeah, there's no such thing.
No, this might be a stupid one. So the sepsis 6 is like, if they ask us what do you need for like treating for sepsis 6, and it's like give antibiotics, do we instead verbalize I want to give remdesivir?
So in this case, we're talking sepsis 6 because sepsis 6 is how we treat patients initially. So in that initial contact, we're not going to know this is for sure COVID or this is for sure pneumonia, right? So you're going to do that you're going to do that broad spectrum shit to start. Then maybe you're going to get cultures that grow nothing, a non-specific white cell count, and a weird-looking chest X-ray and a positive COVID swab. And then you're thinking, okay, maybe we can switch off the antibiotics. But in the first 10 minutes, this person comes in sick as shit with an upper or lower respiratory tract infection. You're not going to know the difference, so you might as well do the whole shebang, right? Sepsis 6 is like an initial management thing. It's not something to carry.
But are we doing like the COVID swab? Is that a rapid antigen test or like PCR?
You're going to say do a COVID swab. Depending on where you are in the real world, like it could be either. They tend to be rapid antigen tests around here in my experience, but
They don't do PCR.
not at all.
Like in Canada and here don't do PCR.
They were still doing RT-PCRs in the States when I was there over the summer, but like things change so fast, it's not even worth thinking about. Just be like, I don't want to get a COVID swab.
They do both.
Okay, here?
You have the getting a minute.
Here.
Oh,
Yeah.
Okay. In the States, you get the swab, and they do both on the, and just automatically would happen. But you get the antigen test fast and the PCR test slow. But look, it fucking changes every day. It's not worth thinking about. Just say I want a COVID swab. What's up?
So if that's positive, do you still treat sepsis 6 until the cultures are back?
So that depends on the situation. Don't worry about it too much. You're not going to get that result back in the 10 minutes, right? In the real world, patient comes back COVID positive, still is kind of borderline. Do they also have overlying bacterial pneumonia? I treat them for both, right? But it really depends on the presentation. It depends on a whole host of factors. So it's, call an audible, whatever you want to do. I'm not your dad. Questions? No? Yo.
I have a question because I don't remember anything about like ARDS. Like, does it come up as a scenario? Does it come up as a thing? How do you like inject this time? How do you treat it?
So how would you treat if ARDS came up? We've kind of talked about all these individual things that can all cause it. How do you treat that? Same way you treat all these other things, right? Ventilatory support, hemodynamic management, antibiotics if they're sick, right? So it's pretty, at the end of the day, kind of all comes back to managing those ABC concerns.
But do you start corticosteroids for if you're suspecting pneumonia, bacterial pneumonia? You wouldn't.
What do you think?
No, you wouldn't. But if you're like, I think it's COVID, there's still there's still a chance of it being bacterial. Would you start corticosteroids?
Do you think this is a call that will come up in the first 10 minutes?
No.
Probably not, right? In the real world, what do you think you'd do?
You wait until you have the results.
Yeah. So you're not going to bang somebody with corticosteroids until you're pretty sure that they're not pneumonic, right? But is this going to be a question that comes up in the first 10 minutes of the scenario? Probably not.
What's the criteria for acute ARDS?
Fine. Google it.
Doesn't, do we, like, is
There's a scoring system for it. I wouldn't know it off the top of my head.
So we're not really ever gonna say like, okay, like this person is.
No, you're going to manage the ABCs.
So yeah, okay.
Yeah.
So he's at rest. He seems
Yeah.
to be
Yeah.
rest something.
Shit's bad. Yeah, exactly. Good stuff. Big brain. All right. No more questions? More questions? We burned through that pretty quick. Managed to slam through an hour lecture in 40 minutes, so it's the first time that's ever happened in our CSI. All right. Feedback forms here. No. Feedback forms here. We're going to get started with scenarios.
So we're gonna. Is everyone here doing scenario today? There might be some people who will Friday. Some people who Friday.
All right, online folks, thanks so much for coming out.